So I want to thank everyone, all the speakers for speaking today, and then we'll move on to the Jones-Smolin lecture. So Dr. Harry Flynn is the Donald Gass Distinguished Chair in Ophthalmology at the University of Miami and Professor of Ophthalmology at the Bascom Palmer Institute. He's a renowned world expert in the field of endophthalmitis. Dr. Flynn has been an author or co-author of more than 610 peer-reviewed publications, as well as more than 100 book chapters. He has been past president of many organizations such as the Vitreous Society and the Retina Society, and the AAO Life Achievement Honor Award and Charles Skippon Award are only a few of the many prestigious awards that he has received. I was happy to find out that in 2018 he was listed as the top 100 most influential people in the world of ophthalmology. On behalf of OMIG, I'm privileged to introduce Dr. Flynn as the 2019 recipient of the Jones-Smolin Lectureship. The title is The New Bugs, New Technologies, and New Drugs, Infectious Endophthalmitis in the 21st Century.
Thank you, Cecilia, for that kind introduction. It is a great privilege and honor for me to give this lecture. And I would like to particularly recognize that Dr. Dan Jones is my mentor and friend, and I even took the liberty of including some of his slides into my presentation today. Secondly, Dr. Gil Smolin was a very prominent infectious disease specialist here in San Francisco, well known for his international work in infectious diseases, and a great teacher here at the Proctor Foundation. I was a retina fellow here in San Francisco, so I must admit that we were influenced as well. So I'm going to move ahead. I have no financial disclosures. The theme of my talk is new bugs, new technologies, and new drugs. I will focus on resistant organisms. Some of the new technologies have already been covered, and new drugs that are coming available. First of all, let's start with classification. This simple classification allows us to predict the most likely causative organisms. Among the acute onset post-surgical endophthalmitis, we think of coagulase-negative staphylococci. We think of Staph aureus, Streptococcus species gram-negatives. Among delayed onset endophthalmitis, we think of P. acnes, Staphylococcus, Staph epi, as well as fungi. For conjunctival filtering blebs, we think most commonly of Streptococcus species, gram-negatives, and Staph species. Then we have other categories that are less common. These include post-traumatic, where we think of bacillus and staphylococci. Keratitis related, we think of Pseudomonas and staph. Intravitreal injection, we heard about earlier, staph and strep, oral flora. And endogenous, we think of Candida, Staph aureus, and gram-negatives. So we just heard a very nice presentation about intracameral antibiotics, including these three choices. So what are the concerns and downsides? Well, antibiotic resistance is one of the concerns. We see this review of our isolates from Bascom Palmer Eye Institute between 1995 and up to June of 2019. We see a fairly consistent rate of resistance among the coagulase-negative staph, the most common cause of post-cataract surgery endophthalmitis, that we're going to miss 30 to 40% of these organisms. And here's an example of a case. This is a patient with coagulase-negative staphylococci presenting after cataract surgery, and the patient was treated with vancomycin. Fortunately, the organism was susceptible to vancomycin, but was resistant to moxifloxacin. So I've collected a number of these cases in recent years that intracameral moxifloxacin was unsuccessful at avoiding the complication of endophthalmitis. What about vancomycin? The concern with vancomycin is that it's our primary defense in treating endophthalmitis. This is our first-line treatment. And we can see that the MIC90s have been rising. These are isolates, again, at Bascom-Palmer, where we tested, and even in our most recent series, 2017 to 2019, we are seeing resistance rates, or MIC90s, that have increased. And here's the downside issue. There have been at least 36 cases in the United States, 23 in Europe, 1 at Bascom-Palmer, at our satellite office in Palm Beach, that had hemorrhagic occlusive retinal vasculitis. This is an immune-mediated response to vancomycin that results in this vasculitis and hemorrhagic retinitis occurring 7 to 10 days after the cataract surgery. So in this unfortunate patient, the patient had cataract surgery in the second eye at a week after, but about 10 days after the first surgery, this became involved in the first eye, and the second eye also developed the same problem. So this can be a devastating, delayed onset disaster. What about cefuroxime? This is another approach, and mostly used in Europe, but it requires, at least in the United States, a compounding pharmacy to prepare the medication, and that can result in contamination. This series from Turkey showed a series of patients that developed fusarium endophthalmitis as a result of contaminated prophylactic cefuroxime. So let's look at the new and persistent microbial challenges. I want to begin with Candida auris and go through some of the resistant staph species. Candida auris is a new multi-drug resistant organism that is responsible for worldwide outbreaks. CDC lists this as an urgent threat in the United States. Here's a patient from New York who was immunosuppressed and developed Candida auris and Pseudomonas endophthalmitis. Ultimately, this eye was enucleated, and it was multi-drug resistant. This study shows that resistance genes are prevalent in this organism, and it can be multi-drug resistant, including 13% of organisms were multi-azole resistant, including voriconazole and others, and amphotericin resistance is prevalent as well. What about Pseudomonas? This is our old enemy for decades, and we see these keratitis cases with advanced infection that goes on to involve the vitreous cavity. Here is a patient with hand motion visual acuity and an advanced ulcer, and this is a type of endophthalmitis patient in which the retinal surgeons and the cornea surgeons work together. My colleague Guillermo Amezcua is doing the corneal surgery in this case, and I'll show the video. We're not quite this fast with surgery, but we sped up the video, and here you can see removal of the intraocular lens and open sky vitrectomy. We use silicone oil in this case. I use silicone oil often in these really bad cases because it does not support the growth of microorganisms. It avoids hypotony and may reduce the rates of retinal detachment. So in these really advanced cases, we can salvage many eyes, and the patient could see with aphakic correction, 2200 in this patient with a normal pressure. Again, this is where silicone oil is our friend in allowing us to salvage a tough case. What about Achromobacter? This is a name change organism. It used to be called alkaligenes. It's a gram-negative motile rod, and it may cause delayed onset endophthalmitis. It's fortunately sensitive to ceftazidime and imipenem. Here's another case. I had a video, but I thought I didn't want the audience to be overly concerned with our aggressive retinal surgery because, again, open sky, silicone oil, removal of the button, and we were able to salvage this eye with 2300 visual acuity. What about Propionibacterium acnes? This is another organism that's changed its name in recent years. It's now Cutibacterium acnes for the cuticle, for the skin involvement, because we find this organism on the skin in so many patients. It has a delayed onset indolent form of inflammation, and sometimes IOL removal can be the only way to salvage these cases. With C. acnes, there are resistance genes that have been identified, and we look for more genes that we can identify to treat these cases properly. Here's a patient sent to me. He had already had a vitrectomy. It failed. You see the white plaque. So we went back and removed the white plaque with a second vitrectomy. It failed again. And so the final procedure was removal of the capsular bag and the IOL. And you can see on the left a keyhole iridectomy was performed to remove the entire capsular bag with scleral depression and remove the lens and perform a complete vitrectomy. But we salvaged this patient, and he's now using a contact lens. So resistance genes are also identified in Staphylococcus aureus, and I'm going to move ahead, but these are cases that are challenging because methicillin-resistant Staph aureus is also resistant to lots of other antibiotics, including fourth-generation fluoroquinolones. And even though we can salvage many of these eyes, they have poor visual outcomes. With methicillin-sensitive Staphylococcus aureus, the outcomes are much better, and we can achieve earlier and better treatment. This is an amazing case, and I put it in to show some of the aggressive treatments that we as retinal surgeons use in these cases. This was a 37-year-old patient undergoing chemotherapy for acute lymphoblastic leukemia, developed fungemia pneumonia, and underwent treatment for a progressive endophthalmitis. In spite of his treatment, there was recurrence, and we used 67 intravitreal voriconazole injections. We published 2 of these cases, and I emphasize that because when you have a bad case, you have to be what many of us call aggressive with multiple injections, because you cannot achieve and maintain the high degree of systemic, of intravitreal coverage with systemic treatment. So this patient was treated twice a week with intravitreal voriconazole over a period of a year. We tapered back towards the end of the year, and you can see from the upper left the original fundus photographs, somewhat improved here, and finally achieved 20/20 visual acuity in his right eye. This was published. My fellow Royce Chen was the primary treating physician in this case. So this is an example of what an eye can tolerate in terms of antifungal medication in these cases. This is a yeast, by the way, and it's not a mold. So what about new technology and diagnostic, molecular diagnostics? We've heard excellent talks so far this morning on this subject. With molecular diagnostics, PCR is an old technique. It's been around for more than 20 years. It has the advantages of sensitivity and specificity and rapid confirmation of the agent, but it has changing standards, few commercial kits, expensive, and requires skilled personnel. So we've heard a lot about next generation sequencing, and this is a technology that's going to help us because using the DNA in vitreous specimens, we can more rapidly and more specifically get the diagnosis we want. So this is one study of 34 patients with endophthalmitis. With this technique, they were able to diagnose the microbes in 88% of the patients, and specific identification of the causative bacteria is possible very early in the course. And it may improve our outcomes if we can identify the specific organism and then provide more focused antibiotic treatment for that organism. What about therapeutics? Before 2000 in antifungals, we had a certain number of agents, and then after 2000, we have even more. So how do we stack up and compare these agents? Well, we've looked at these in our microbiology lab here at Bascom-Palmer. We looked at a host of these, again, against Candida isolate 17 at Bascom-Palmer. And looking at MIC90s, voriconazole still comes out as the top antifungal agent, along with amphotericin B. So in the really bad fungal cases, I will use both in treating these patients. Here's the patient that Dr. Ye had earlier of a patient. This was actually a physician who came in after cataract surgery with pain and decreased vision. She had already had a vitrectomy, had already had identification of the organism. We treated conservatively at first with more injections, and again they failed. So at this time we went back to do a penetrating keratoplasty to remove the plaque of involvement of the cornea, as well as vitrectomy to remove the IOL and capsular bag. And this is the patient after surgery with the corneal transplant. This is the corneal button showing infiltration of the cornea with Candida parapsilosis. And this is the capsular bag showing organism in the capsular bag. And this is the reason why we were unable to cure this patient with simply a vitrectomy. Sometimes we have to go back and remove the bag. This is the patient 2 years later. She does use a contact lens, and she is a physician here in practice in the Bay Area. And she has a macular epiretinal membrane, which has remained stable as the reason for her poor vision. What about all of our exogenous fungal cases looking at susceptibilities over a 20-year period? We collect and freeze our specimens so they can be used for future studies. We took 47 isolates, both mold and yeast, and had them evaluated in a microbiology lab to give us MICs. And of all of the agents we tested, voriconazole is still the best at the lowest MIC. And so intravitreal voriconazole appears to be the broadest spectrum of antifungal coverage, and this is the agent that is also the least toxic. So when you're considering which agent to use, I would certainly say voriconazole should be on the top of your list. What about coagulase-negative staph? As I mentioned earlier, coagulase-negative staph is our enemy in cataract surgery and most ocular surgery cases. And we can see here, if we look at methicillin-resistant coagulase-negative staph, the MICs for vancomycin are still quite good. Even new antibiotics like bezifloxacin would still be in the resistant category. And look where moxifloxacin is. It's way down on the list of effectiveness in terms of MIC90s. If we look at methicillin-sensitive coagulase-negative staph, the vancomycin is the same. Actually, moxifloxacin was much better. So it's interesting, this dichotomy between methicillin resistance and methicillin-sensitive cases of coagulase-negative staph. We have an ongoing study. It is submitted to the AJO. We had a total of 45 Staphylococcus isolates. Vancomycin was 100% effective, and we looked at a new fluoroquinolone, delafloxacin, and it had a substantially lower MIC90 at 0.98, which is quite good. And I think we're going to hear in the future a lot more about delafloxacin. It's not commercially available, but it's going to be in the future. What about our first-line agents for management of endophthalmitis? Well, among antibiotics, we use vancomycin 1 milligram and 0.1 ml for coverage of gram-positive organisms. We use either ceftazidime, 2.25 milligrams and 0.1 cc of fluid. Amikacin is used also as an alternative for gram-negative organisms, and we use 0.4 milligram per 1/10 ml. For antifungals, again, I mentioned that voriconazole is our top choice, but amphotericin B also works quite well. And I'm going to now refer back to the named part of this lecture, Dr. Dan Jones, our friend and colleague and mentor for decades. And I talked with Dan a couple of days ago and mentioned that I was going to use some of his slides. And this slide, this presentation was given at our 50th anniversary scientific meeting in February of 2012. These slides are still pertinent today. And we talk about environmental factors that influence microbial evolution. Environmental factors include antibiotics used in agriculture, environmental change due to many other factors. These environmental factors may allow the emergence of new infections and new microbial challenges. The new infections result in the use of increased antibiotics during surgery and for prophylaxis. This, in turn, changes the environment of the pool of organisms that challenge us in medicine. And in turn, that allows for selection of intrinsically resistant organisms and the development and evolution of new strains. This, in turn, forces us to use more antibiotics, and we're caught up in this vicious cycle of trying new antibiotics. So I think we still have a lot to learn, both in the use of antibiotics prophylactically, but choosing the right drug to treat infections. And I thank Dr. Jones for these slides, which helped my presentation. I'd like to acknowledge my colleagues at Bascom Palmer, Darlene Miller, who runs our microbiology lab, Dr. Batra, one of my fellows who has helped me on multiple projects, Suleiman Al-Humad, who's a fellow with me, and Alex Rodriguez, who helped me with the slides. And I would again like to recognize these two leaders in our field, and thank you to the organizing committee for the opportunity to present this lecture. Thank you. I think we have time for questions if there are some from the audience.
So that was an excellent lecture, Dr. Flynn. I just wanted to make a comment, actually, that even I've had patients where I've had to inject intravitreal voriconazole and amphotericin B for up to a year repeatedly in patients with endogenous candida or post-intravitreal injection aspergillus endophthalmitis. So it goes on for a year. And when you stop the injections, the infection comes back. And so that's my...
Your point is well taken. I think that many ophthalmologists don't realize that you can be aggressive long-term. They often develop an intolerance for the systemic antifungals or systemic antibiotics. So you're forced to use something locally. And that's where we have been changing the old way of thinking that, you know, you have to do an injection, and perhaps maybe in a certain number of cases you can come back in a few days or a week, but to inject twice a week is a little bit different mentality.
And sometimes some patients developed hypersensitivity to the amphotericin B after 5 months or 6 months. So we just had to carry on with voriconazole then. I
fully agree, because I think you're concerned with toxicity, RPE toxicity, optic nerve toxicity with amphotericin B. So you really have to be careful with it. But voriconazole is much more forgiving.